Okay, so welcome everybody and happy International Women's Day as well. I'm Karen. For those of you that don't know me, I'm the co-director of Finesse Movement, and I'd like to welcome all our members and those that are joining us for the first time to the first of our spring masterclass series. So this is all really, really exciting. At Finesse, our mission is to have a positive impact on our clients' lives by helping them regain and maintain pain-free functional movement through physical therapy and reformer Pilates. So that's pretty much what we're all about. We're particularly passionate though about all things women's health, be that prenatal, postnatal Pilates. We have a women's health specialist physio. So it just kind of made sense that menopause is another women's health issue that has been, it's kind of getting up there with some media coverage, but it's very much a taboo subject still, in my view. So with that in mind, I'm a woman of a certain age, and I noticed some changes in my body over the last few years. I put these symptoms really down to stress or overtraining in the gym, or not having enough sleep, or just not taking enough rest. And it wasn't until I met Maureen and we had a conversation around the perimenopause that I put, I just got all these kind of just light bulb moments of, oh my God, yeah, I really didn't think of it like that. Because I really did think I was going mad. I actually thought I was experiencing, onset early dementia even, with just how I just wasn't able to remember, like the flow of a class, for instance. I might be teaching a class. And luckily my clients are fantastic and they kind of, they muddle through with me. So when Maureen explained the physiology of menopause, all the pieces started to fall into place. So that's what brings us where we are this evening. So for the next hour or so, Maureen's going to share her specialist knowledge on the menopause to empower each and every one of us to make evidence-based decisions regarding our future health during our menopause. So I'd like to formally introduce the wonderful Maureen O'Dwyer. Her list of achievements is actually mind-blowing for one so young. She's a graduate of the University of Ulster. She's a registered mental health nurse. She also holds a certificate in exercise, nutrition, and personal training. So she's a practitioner. She's also qualified in yoga and Stop Pilates. So Stop Pilates is a school of Pilates that myself and Eleanor have also trained in. And also she's a certified executive and life coach. And she's currently working towards her accreditation to become an interpersonal psychotherapist as well. I was just like blown away when I read all that bio. She definitely has a special interest in women's health. She's just, her knowledge is just mind-blowing. And she recently completed a training program with the British Menopause Association, which is designed especially for nurses on advising women on symptoms and treatments for perimenopause and postmenopause as well. To add to all that, she's lived in the United Arab Emirates for a couple of years with her family. And now she works in Highfield Healthcare in Dublin, where she facilitates individual and group therapy sessions in anxiety management and the management of mood disorders. So before I hand you over to her, I just want to get a couple of pieces of housekeeping just out of the way. So we're going to keep you all muted throughout the presentation, and there'll be plenty of time for questions afterwards. If you want to use at that junction, if you want to use the chat function just down below on the screen to pose your question, then we'll be the question masters. If you want to ask a question anonymously, you can do so. You can message us privately, and we'll just ask the question outright. Also, I want to say that this is a safe space for everybody here, because obviously there will be people talking about their experiences, and we would like people to share their experiences and just to get something out of it. And we just want to respect everybody's privacy in that regard. And then finally, there's absolutely no need to this is not a lecture, so there's no need to take any notes. If you just listen to Maureen, listen to the presentation, she's kindly agreed for us then to email you everything after the session. So just sit back, relax, and I'll hand you over to Maureen now.
Brilliant. Thank you, Karen. And I didn't recognize that person you described. That's very kind. I'll enjoy listening to that bit of the recording over and over again.
Great, isn't it, when you hear about yourself?
Yeah, it really is. So thank you, everybody, for attending. And we'll all be finished in time to see the Harry and Meghan interview because, you know, priorities and all that. So the presentation, I think it'll be about 40 minutes. So I've just put together all the basic information of, you know, what is menopause, the symptoms of perimenopause, our treatment options, lifestyle options. And then there's resources. I'll be talking about resources that then you can go on to get more information as well. And like Karen said, you don't have to take notes or anything, just sit back, relax. And everybody will receive a copy of the presentation afterwards, and so just use it as you want. So I'm just going to share the screen here, and which one was it now? This one. Sorry, hopefully it's the right one. Yeah, brilliant. So this is Finesse Movement, and Karen and Eleanor have kindly let me come on today on Women's Day. We really wanted to mark the day, and it's really, really important. There's so many women's issues, of course, but, you know, menopause affects every single woman. You know, if every woman is going to live to menopause age, they're going to go through it. Nobody is not going to go through it. That's just the physiology as well. So it's really important that we know, we break the taboo on it, there's so much misinformation out there as well, a lot of scaremongering. Of course, there's, you know, risks to treatments and everything as well. So it's about that sort of benefit risk that everybody can do. And each woman is individual. So each woman is going to experience different symptoms and require different treatments. So the first slide is, hang on, why won't it let me move? Here we go. So menopause bingo, I really liked this one when I saw it. In terms of it kind of sums up all many of the symptoms of a menopause, which we're going to go through in the presentation as well. And like Karen said as well, you know, menopause can make you feel crazy. And then, you know, when you find you've reached the bottom of craziness, there's a crazy underground garage. And I have to say, that's what fueled my interest. I've always been interested in everything got to do with women, and especially in the mental health field. I worked in homeless services for a long time as well, and from the other side as well. And so it was my own personal journey with starting off when I was about 44, I think it was about 41, 42. So, you know, strange things happening like itchy skin, dry eyes, hair getting really dry. I've always had really good skin. My skin was getting drier, and just this mad anxiety coming out of nowhere when everything was fine, low mood, low libido, and then you'd be fine for a while, and then it would hit you again. And then when I was about 45, I just really felt it was quite relentless. So it wasn't until I started, like Karen said, you start putting things together and you realize, oh, hang on, there's something here. So I'm trying to, so I get most of my information, virtually all my information, from the British Menopause Society and from Dr. Louise Lewson, the menopause doctor. Her website is amazing. It has all non-biased, evidence-based information. She has her own private menopause clinic in Stratford-upon-Avon. She has a most fantastic podcast. I'm always sending podcasts to my friends. Some of them are on this tonight, so they'll be acquainted with Louise Newson. But she's brilliant. She's one of the leaders in the field. So you can't go wrong if you go on her website. She has all the answers to everything. Her Instagram is fabulous as well, and it answers lots of women's questions on Instagram. So she has, this is her app. So if you do nothing else after the talk tonight, if you download this app, it's really simple. It's brilliant. It's got all the information, symptom tracker on it. It has a community as well. So different women talking about different things like depression or sleeplessness or itchy skin or vaginal atrophy. So this app is really, really simple. You know, all phones, it's in Android and the Apple and everything. It's free as well. And also Louise Newson has just recently set up a menopause charity. So she wants to start a charity, start fundraising, and then because there's a lot of women who, you know, a lot of menopause care now is private, and even in the UK, in the NHS, they've menopause specialists, but not enough. A lot of GPs wouldn't be educated enough in menopause, unfortunately, at the moment. So women have to go privately. And, you know, a lot of women can't afford to go privately, and a lot of women can't afford, if they do decide to take some treatments or HRT, they can't afford it every month. So she's starting that as well, so Equality for Women, which is brilliant. So they're just building the website at the moment. So what is menopause? So I think everybody probably knows menopause is the normal natural event defined as the final menstrual period confirmed after 1 year of no menstrual bleeding. It represents the permanent cessation of menses resulting from loss of ovarian follicle function. It's usually due to aging, but it can also happen as well. Oh, I see a typo there. Oop, I'll fix that. It'll due to surgery as well, and different medical treatments like cancer treatment and radiation as well. So when is in the Western world, the average age is about 51. With Asian women, it can be earlier. It can be around 45. You can go into menopause prematurely, like I said, from if you have your ovaries removed, if you're going through chemotherapy for various cancers, and also any time from impaired ovarian function. Actually, I listened to a podcast last week on Louise Newson from her youngest menopause sufferer, who was 14, and she had gone through menopause from chemotherapy. So it was essential she go on estrogen to protect herself. So it was really interesting. And by the way, on the opposite way, Louise Newson, the oldest lady that she's treated, was 91. So it's, you know, it's all ages. So premature menopause is determined any time before age 40. So the NICE guidelines, the NICE is the National Institute for Health and Care Excellence in the UK. It's what all the medical practitioners would have to adhere by. And we do here in Ireland as well, like we would adhere to the NICE guidelines for treatment of depression, anxiety. And for menopause, so blood tests for you women under 40 to measure the FSH, follicle stimulating hormone, and luteinizing hormone are helpful. Between the ages of 40 and 45, again, may be helpful. But over the age of 45, it's not, because it can fluctuate so radically from hour to hour, day to day. So normally women under 45 and under 40 would have a test and then another one 6 weeks later. Still too many GPs, including my own, insist on you must have a blood test. They're using it to diagnose perimenopause, when in fact it's not a biochemistry diagnosis. It is a clinical diagnosis. So you listen to the patient, you listen to what they're reporting. Perimenopause, that's the time around menopause, and that's the one we're going to focus on most tonight. It's the menopause transition, and it's the most symptomatic phase. So that's the one where both Karen and I were talking about, where we thought we were, you know, firmly ensconced in that crazy underground garage. But, you know, we realized, no, we're not. It's just the symptoms of the perimenopause. Then there can be induced menopause, like I said, from the different surgeries, the chemotherapy, for radiation, just anything that's got to do with medicine, the iatrogenic. And then postmenopause, like we say, is the years after the final menstrual period resulting from natural, spontaneous, or premature. So nowadays, with current life expectancy, in the postmenopausal years can make up a third to a half of the lifespan of most women in the Western world. So most of us are probably hopefully going to live to minimum 80, hopefully 90, you know, maybe some of us 100. So we want to make sure that these are good quality. Because back in the Victorian times, we died about 5-10 years after menopause. So it really didn't matter too much, you know, because we weren't around too long. So we want to have a good quality of life. For a lot of us at this age, at 50, we're right in the middle of the careers. We still have another, you know, 20, if we want 20 years of working, we've still loads of traveling to do. You know, the children are hopefully leaving home. And there's so much we want to do. We want to be healthy. So these are the 7 stages of menopause. I'm sure some of you or all of you can relate to this. I certainly have experienced all this, and some of it all at the same time. So I just love this one. It kind of sums it up nicely. So the perimenopausal symptoms. So these are really the most troublesome and irritating part of the whole menopause process. So this is a really important little sheet here. Afterwards, if it's on Louise Newson's website, it's on Liz Earle's website. This is the climacteric green scale. So this is what all clinicians will use to get that clinical diagnosis of perimenopause. So it's not, like I say, the blood test. So if your GP is saying it's just a blood test, that is incorrect. So you can see here the symptoms: heart beating quickly or strongly, feeling tense, difficulty in sleeping. You'll see a lot of these here. So you'll see a lot of the symptoms, especially the ones, loss of interest in most things. That's called anhedonia. You know, we'd see that in depression, feeling unhappy, crying spells, irritability. No wonder your GP would say, oh, hang on a minute, you're depressed, here's an antidepressant. When in fact, when you put everything together. So it's when I started doing this. So my main symptoms were palpitations. So imagine how frightening that is. A lot of people go to cardiologists with this. That's another thing in my work. That's what made me so curious as well, just curious about myself and what I was going through. And then I started, because I had that empathy piece, and I started noticing women coming in, especially early 40s, mid 40s, and just saying, I don't know what's happening to me. I was fine. I've never had this before. Maybe I had a bit of postnatal depression, but, you know, I've been to the cardiologist. I've been, a lady there 2 weeks ago had been to a cardiologist, endocrinologist, and had also gone about the person who looks at the rheumatologist, or the person anyway who deals with the arthritis and things like that. And that's what's happening, because you go to the GP and they're referred and referred. So you can see this list, by the way, is not exhaustive. There is at least 64 symptoms, but these are the main ones. And obviously you have to be more targeted when you go to the GP. So it's really, really important when you go to the GP that you have this, that whatever healthcare provider you're going, so they know, they can see it all together. Because if you just go and mention a couple of symptoms, well, yeah, that can sound like depression, or it can sound like anxiety, or it can be the joint pain, the arthritis. You can see the GP, you've only got, what, 10 or 15 minutes? So this is really, really important, this one, and with the symptoms as well. So the other symptoms as well is obviously the menstrual bleeding changes. Some people don't get many changes. Other people, lighter, heavier duration, the cycle, you know, you can start to get a period every 3 months. And I used to get every 3 months, and then I might get 4 in a row for 2 weeks, or mad stuff like that. Sometimes people have no changes. And a lot of women have reported to me, they go to the GP, they say, and the GP said, are you still having periods? Yes, well, then you're not menopausal. But no, it's not about that. It's just about the change, and there may be no change at all. Also, premenstrual syndrome can become worse in the perimenopausal years as well. That's the vasomotor symptoms. So that's the hot flushes. So They're recurrent transient episodes of flushing accompanied by a sensation of warmth to intense heat on the upper body and face. So I never had a hot flush ever. So, but I've seen people and people have reported it to me. There's a fantastic podcast with Liz Earle and Kirsty Lang, who is the newsreader and journalist with Channel 4. And she talks about she had treatment for breast cancer and how it left her with no estrogen, and she was having hot flushes every hour, and it just sounded horrendous what she was going through. As many as 75% of perimenopausal women report hot flashes, and it's triggered by small increases in the core body temperature acting within a reduced thermoneutral zone. So the hypothalamus in the brain, we've estrogen receptors all over the body. So that's the thing, the hypothalamus, think of it like your heating system at home, and your boiler is starting to malfunction a bit. So everything is going to kind of go into overdrive to try and balance out. And that's what's happening. So treatment is based on symptom severity and a woman's risks and personal attitude about menopause and medication, which we'll look at further down the line. So this really, I'm sure some of you here can relate to this and have experienced this in terms of you start to get hot and then it comes just up all over your body, and then you cool down again and then get shivering. So it can be, especially if you're in work, if you're in a meeting, if you were doing a presentation like this, it would be quite disconcerting to be having a hot flush and the chills. So obviously in our 20s, we did flash dance, and now all we want is the cool water from the hot flash dance. I'm sure Deborah Winger is doing the hot flash dance as well now. So vaginal symptoms. It's really, really important we talk about this. I had a client in with me last week, a lady that was really quite unwell. We've known her for quite some time, and she's doing brilliant now, and she's really well on the way to recovery. And she said to me that she would like a partner, and she was joining a dating site, and she'd love to have sex again, but she can't because, she pointed and went, it's kind of sore down there. And I went, oh my God, I can't believe you're talking to me about this. This is fabulous. So I gave her lots of information about vaginal atrophy. I told her about the local estrogen in badges, sent her off to a GP asking for that, and just said, yeah, you don't have to put up with that at all. It's really, really treatable. And even the local vaginal estrogen, even for women who have estrogen receptive breast cancer, can take it because it's a tiny, tiny, tiny amount, but it really works brilliantly well to help with all the dryness and irritation. So a lot of women it can impact on their daily life so much, like 40% of women can't wear jeans, they can't sit down. For women, they can't have sex, so that really affects their relationships. So it's really can be quite simple to treat, but women need to talk about it and need to be open about it with their GP. So unlike the vasomotor symptoms, which abate over time, the hot flashes, the vaginal atrophy is progressive. It's to do with old age, and it affects 100% of women as they mature. It depends on your genes. It depends on, your activities and what you do and don't do and eat and exercise and everything, how much it's going to affect you. So the treatments, like I said, so regular sexual activity, if you can get it, use it or you lose it. Okay, so lubricants, moisturizers, and like I said, the local vaginal estrogen. So that's that. And here's a little picture. So, so you can see on the left-hand side, that's the healthy vagina, and then you can see it just goes really thin. So can you imagine, like, if anything rubs off, or that sexual intercourse, that penetration is going to be, it can be really sore, and over time it's just going to get worse. So if you take the vaginal estrogen, then it starts to get healthy again because the receptors are fed. So sexual issues increase between the ages between 45 and 64. And I know there's lots of jokes about, oh, you know, I'd rather read a book and things like that. But, you know, it's really important, and especially in relationships, it's really, really important that we have that part of our life. So decreased estrogen causes a decline in vaginal lubrication and elasticity. Decreased testosterone may contribute to a decline in sexual desire and sensation. So for a lot of women as well, especially, you may have the lubricants, the moisturizers, and the local estrogen. So you can have sex, but you may not necessarily want sex because of the testosterone and the low libido. So you do what you have to do for your relationship, but it's a difference between having and wanting. So again, to keep the good sexual health is the active sex life, the lubricants, moisturizer, systemic and local estrogen. Systemic is when we take HRT, where we take estrogen through patches or through the skin, and local estrogen through the vagina. They help maintain vaginal health along with testosterone replacement. Not everybody is suitable for testosterone replacement, but again, the main things with testosterone replacement is low libido and brain fog. If you've got those two, which I did, testosterone is suitable for you. So that again is with a lot of GPs won't prescribe testosterone because it's not licensed for women. I mean, you can still prescribe it, but it's prescribed off license. So the specialist places like the Menopause Hub and Deirdre Ford, Dr. Deirdre Ford would prescribe it. So we all know the health benefits connected with regular sexual activity. So it's really important at this age not to just say, right, that's it, you know, closing up shop at the end. This is really important for a really good life. So reduced cardiovascular risk, inflammation, improved mental health. That's one thing here we're very big on here. The consultant psychiatrist I work with, Dr. Miriam Kennedy, is fantastic. And we look at every part of a person's life. And if somebody, you know, tells us that their sex life isn't good, we'll look at the medication, we look at ways. Miriam has a great little bundle of medications, can help boost people in that department. And it's just life-changing for people. So it improves white blood cell count, you know, helping with infections, reduced cortisol, and increases longevity. So sleep disturbances, which, see, that is really the biggie, isn't it? So I just love that picture there. I use that in the compassion focused therapy as well. Poor little doggy. But yes, how many days have you felt like that? I just can't add up today. Some days I just say, it's so hard being a grown up, and especially when you're tired. So peri and postmenopausal women sleep less, have more frequent insomnia, and more likely to use prescription sleeping aids. And we would see that here in work a lot. Hot flashes, night sweats can trigger awakenings in the first half of the night, but then REM, when we're dreaming, in the second half of the night suppresses the thermal regulation, reducing the hot flashes. And then nocturia, frequent urination at night, is a common symptom of perimenopause. That was something that was really troublesome for me. Some nights I was getting up 4 times in the night. It was really like I was just exhausted the next day. So that compounded the anxiety, the low mood, you know, the feeling that you can't cope. So that piece was really, really tough as well. So again, people experience this on different levels, but it is certainly really, really common. And sleep is so, so important for us. And more research is being done now on the importance of sleep and just for our health and general well-being, for preventing, you know, the amyloid plaques in the brain in terms of the Alzheimer's and everything like that. So it's really important. And also we have other issues that keep us awake, like, you know, who you share the bed with. So do man say, I like this one, the snoring is keeping the dog awake. So cognitive changes. That was, sometimes I'd be in groups and, you know, you're going around talking, asking each person a question, getting participation. And I'd come to say, Karen, and I'd go, I can't remember her name. Oh my God, I've been working with her for, oh my God, or Jane, or whatever. And it was really scary. And loads of times I'd be, you know, in SuperValue, and I'd meet somebody who I know well, or somebody from the school or something, and I just couldn't remember their name. Sometimes I had to go on somebody else's Facebook page to find out the name of that person. And then I'd be like, oh, yes, hello, how are you, Claire? Yeah. So, yeah, that was brain fog. Actually, some people feel like they're getting dementia. They feel like they're really, really scared. Then the anxiety as well. Anxiety can affect your memory as well. Louise Newson, if you go on her website, she's done loads of work with West Midlands Police and how brain fog, how it's dangerous. It is dangerous for women who are in jobs like that, that require quick thinking and decision making, and they have to be really careful about it. And that's where the whole piece about menopause in the workplace comes in as well. So it's about, I suppose, with the cognitive changes, knowing that brain fog is part of the low estrogen in the brain and the low testosterone. Before menopause, pre-menopausal women, we make 3 times more testosterone than we do estrogen. Because testosterone just got this kind of male, I don't know how it happened or when it happened, this Charles Atlas type male thing. But testosterone is hugely important for females. And even, you know, that piece of going to the gym and doing weight training and everything, it's impossible. We can't end up like Fatima Whitbread unless we, you know, really train and do everything like she does as well. So that's really important to know that the cognitive changes are just the part of the perimenopause as well. And then mood changes. So that's a lot we would see here as well. In terms of, now we treat obviously clinical depression, but we would often have people in with anxiety and the low mood, and then women in their 40s as well, where the low mood is related to fluctuating hormone levels. So an antidepressant is not going to help you if it's just fluctuating hormone levels. It may help a little bit, but it's going to level off at a point. So what really helps is replacing the estrogen. So women with a history of premenstrual syndrome, significant stress, sexual dysfunction, physical inactivity, and hot flashes are more vulnerable to depressive symptoms as well. And a lot of that as well to do with the exhaustion, the lack of sleep, the high stress as well. And then the most predictive factor for depression at midlife and beyond is prior history of clinical depression. And, you know, having worked in this area for a long, long time, it can be well managed, well treated, as long as you know and you know yourself and you know your early warning signs as well. So that's the piece about the mood changes. And quite often women go to their GP and they're just given an antidepressant straight away. It happened to one of my friends, and she was genuinely, I'm trained, I can assess her. She is not depressed. She was not depressed. I said, do not take that antidepressant and go elsewhere, because she didn't need it. It was the perimenopausal symptoms. So there we go, mood swings available every 10 minutes. I'm sure you've all felt like that at some stages. So urinary symptoms, really, really common as well. A lot of women, you know, are going, another lady I had in recently was going to a urologist and back and forth and couldn't determine what's wrong, overactive bladder. Nobody had mentioned perimenopause to her. You know, she was 52 and I had mentioned it to her, and she said, oh yeah, I had heard of that, but no doctor, nobody had ever mentioned it to her. So mild incontinence in early perimenopause is very commonly reported. And again, the Kegel exercises, which, you know, Karen and Eleanor would be brilliant teachers and advocates of. It's really, there's a lot of evidence to show that they really work. And weight loss can really help as well. And so these symptoms, they go along with the vaginal atrophy as well, because there's estrogen receptors all over our body, and tons of them around the pelvic region, the vaginal region as well. So urinary incontinence is very, very common as well. So the localized estrogen can really help with urinary symptoms. So if somebody didn't want to take systemic HRT, the localized vaginal one works really well for the urinary symptoms. Osteoporosis, so there's a big risk of osteoporosis, especially post-menopause. So it starts sort of in the perimenopause. So 13 to 18% of white European women 50 plus have osteoporosis of the hip. It costs like billions for the NHS every year, and again here in Ireland as well. And lower estrogen levels account for about 2/3 of bone loss during the 5 to 7 years around menopause. My own Auntie Maureen, who I'm called after and look like her and small bones like her and everything, my Auntie Maureen was on HRT and then was taken off it because of the scaremongering from the Women's Health Initiative. And then my Auntie Maureen died in a huge amount of pain 18 years later with terrible osteoporosis. She one day coughed and fractured a bone in her vertebrae. So that's why I've always gone to the gym for as long as I can remember. And the prevention for osteoporosis was one of the main drivers for me to look at my whole menopause health. So low intensity weight bearing exercises such as reformer Pilates are excellent to maintain good bone strength. So you can do a lot to help yourself as well with exercise, good nutrition, not smoking, drinking very little. But really the estrogen is, you can do all those things, but if you've got that genetic component, it's going to happen. So they're the bits there. Long-term use, glucocorticoids are steroids that can really affect the bones as well. So a lot of women can be put on that for the joint pain that they complain about in perimenopausal symptoms. So cardiovascular disease, I'm surprised at the amount of women that don't know coronary heart disease is the leading cause of death in women post-menopausal. When I did the course, the figures they gave us, they said that 120,000 women a year die in the UK of coronary heart disease, compared with 12,000 women who die of breast cancer. Whereas most people think it's the other way around because that's the way the media has portrayed it. So the risk of overall coronary heart disease, fatal coronary heart disease, cardiovascular mortality, and overall mortality was shown to be increased in women who became menopausal under the age of 45. And that's why it's really, really important if women can't take estrogen under the age of 50. There's no increased risk in breast cancer, and it really helps with the prevention of cardiovascular disease. And estrogen may have a protective role in coronary heart disease prevention, especially if initiated in women below 60 years and within 10 years of the onset of menopause. So Louise Newson will quote on her site that it actually gives us 60% protection. So it's huge. So our risk of heart disease is at postmenopause is the same as men, because men don't have that estrogen protection, they never have. That's why they're at risk so much earlier as well. And also we get the we start to get the belly, we start to get the beer belly like the men, because our body is desperately trying to make estrogen, and there's estrogen in fat cells, but it's not a good estrogen. So you notice all of a sudden, you notice that all your weight, you're suddenly getting that beer belly kind of look. And that's what really contributes as well to the visceral fat contributing to the cardiovascular disease. So if there was one take-home message that we got on that course with the British Menopause Society, was to ensure that women know the risks, the health risks following menopause, just to make sure that they know the information and they can make informed decisions from that. So the management, how are we doing? Oh, we're okay, I'll fly on. Menopause, so what you're saying is I'm looking forward to 10 years of health followed by death. No, it's not that bad. So the first line treatment, and as determined in the NICE guidelines as well, is body identical hormone therapy, which is a pharmacological therapy approved for treating menopausal symptoms. And hormone therapy encompasses both estrogen alone and estrogen progesterone therapies. So hormone therapy since 2002, when the Women's Health Initiative came out, which by the way has been, the authors came out in 2018 to say a lot of it was a very flawed study, and it's really kind of the media got on the back of it. If you read Avron Blooming's book, or even Louise Newson or Liz Earle, you'll get all the information, because that's a whole different talk. And I didn't want to go into it now, but there's loads of information about it. So just to explain what hormone therapy is. So you can have the estrogen-only therapy. That's systemically for women who do not have a uterus, and locally in very low doses for any woman with vaginal symptoms. Systemically means normally you take it orally, or nowadays most people would have a patch, or they have a gel, so it goes transdermal, which really reduces the side effect risks. And then for women who have a uterus, you'll add in progesterone. Mostly these days it's utrogesterone, which is a micronized progesterone made from yams, which is actually identical to our progesterone. And so far studies are showing it does not increase the risk of breast cancer, and very little side effects for women. And you can reduce the side effects even more by placing the capsule in your vagina, so it's not going through the liver. When you take anything orally, it's metabolized through the liver. And then you'll hear of bio-identical hormone therapy. So body identical is what the clinicians will prescribe. But be careful, there's bioidentical, and these consist of hormones chemically identical or very similar to those made in the body. But these are unproved and untested from compounding pharmacies. They're not prescribed by menopause specialists and GPs, so they're not licensed, so they're not, just be very careful. There's a lot of clinics and they're very expensive as well. So I don't know much about them, and I have never met anybody who's used them either, but that's the message from them. So what do we need to know about hormone therapy from the recent studies? Well, significant reduction in breast cancer diagnosis and mortality in women using estrogen-only HRT. Women on combined estrogen and progesterone containing HRT had a slight increased risk of breast cancer diagnosis, but no significant increase in mortality. The micronized progesterone, the utrogesterone I just spoke about, and digosterone are likely to be associated with a lower risk of breast cancer compared to that seen with other progesterones. And healthy women taking combined HRT for 10 years immediately after the menopause had a reduced risk of heart disease and dying from heart disease by 60%, which is huge. HRT has a role in the prevention of osteoporosis, but long-term use is required. So the minute you stop, then the protection of the osteoporosis stops. The dose and duration of HRT use should be made on an individual basis after discussing the risks and benefits, and no arbitrary limit should be set on duration of use. So I was told, oh, you go on HRT for 3 years, oh, maximum 5, smallest amount for the shortest. So I said, where's the evidence for that? No, that's just the way it is. There is no evidence for it. It's no evidence. So women can be on, basically women can stay on it as long as the benefits outweigh the risks. And for a lot of women, that'll be the day they die. HRT users are assessed by their GP or healthcare provider once a year. So these are the risks. So if you're under 50, there's no extra risk. If you're over 50, the background risk per 15 per 1,000 is 2 to 6 extra cases. With ovarian cancer, it's an extra 1 case over 5 years. Endometrial cancer, so combined HRT protects the endometrium, maybe a 4 extra cases over 5 years for estrogen only. Yes, and other people will be told that, the risk of stroke, but if you take estrogen transdermal through the skin, through the gel, there is no risk at all. And the risk comes from orally taking it through the liver. And cardiovascular disease, there's no risk at all. And GPs are still saying there is, but there isn't. There's no evidence. So this is brilliant. This is really good. It's on the Women's Health Concern. I have it on the back, and it'll just show you the risks. So this is from the British Menopause Society. So you can see this is per 23 cases of breast cancer diagnosed in the UK general population, per 1,000 women aged between 50 and 59, sorry. So you'll see 4 cases, an extra 4 cases for women on the combined hormone replacement, progesterone, estrogen. 4 fewer cases. That's the preventative. Years ago, breast cancer was actually treated with estrogen. So there's 4 fewer cases for women on estrogen only. There's an additional 4 cases for women on the combined hormonal contraceptive pill. And there's additional 5 cases. So if you like to have a glass of wine or 2 glasses of wine a night, you're increasing your risk by 5 cases. So your risk is higher than it is for HRT. For women who are current smokers, it's 3. And this is the bit that women really need to know. The additional 24 cases in women who are overweight or obese with a BMI equal or greater than 30. So that's a huge risk factor. And then 7 fewer cases of women who take at least 2.5 hours moderate exercise per week. Walking is plenty. You don't have to be in the gym. You don't have to be running. You don't have to be doing CrossFit. Walking is plenty. But the weight thing is huge. And if women don't treat the symptoms, if you're not sleeping well, if your mood is low, if you're feeling anxious, I mean, it's really, really hard to eat well. It's really, really hard to get out there and exercise. So that's the piece with that. There is alternatives as well, because there is a small minority of women that can't take HRT, and there's other women who choose not to, which is perfectly fine. So you can take some antidepressants that will help with the hot flashes, especially venlafaxine is very good. That's the studies that have been done in terms of the hot flashes. Obviously for zopiclone for sleeping, but you want to take that for the shortest amount of time. Anti-epileptic medication, gabapentin, that's very good as well for helping with hot flashes. Clonidine, which is a blood pressure tablet, and pregabalin, which can help with the aches and pains in the body. These all have side effects as well, and not really to take long-term either, can just help ease the symptoms, especially if the hot flashes are interfering. Or you could take them all in one big convenient dose like that if you like. So also we have the complementary and alternative medicines, and we did a whole afternoon's work on that when I did the course as well. So Louise Newson on the Balance app has a little page on each one, and black cohosh, St. John's wort, valerian, really interesting. So there's very little evidence to show that these help. But, you know, women do report they do help. So just be careful because especially black cohosh, St. John's wort, they can interfere, contraindicate with other medications as well. If you are going to buy supplements, make sure that they have this certification mark on them. If they don't have this certification mark, don't buy them. This is a quality standard. It doesn't mean there's research and evidence to say they work. It just means they're made to a good quality standard. So that's really important. Just keep that in your mind if you're looking at supplements. You'll see nowadays there is, like in Boots, there's a whole section on menopause and tablets and everything. Like there's a whole industry starting now with all sorts of, like with lubricants, you know, the ones that are recommended are Yes and Silk, which they have in Boots, and Regal. But there's a plethora. Don't get any of these smelly ones and different ones. You don't need to be interfering with your vagina like that. It's perfectly fine the way it is, and just a nice, gentle lubricant, simple works. So we have the other lifestyle changes as well that you need to be doing, even if you do choose to take medication or HRT. I mean, we just need to be doing this anyway. So relaxation techniques, really important. Yoga, mindfulness, meditation, healthy diet, regular exercise, for example, pop down to Karen and Eleanor, and the Pilates is amazing because that brings in the whole mindfulness and meditation piece as well. Have a healthy body mass index. Try and keep your body mass index if you can under 25. Keep an eye on it. Keep alcohol consumption to the recommended weekly allowance. Really lower if you can, because every alcohol drink does increase the risk of breast cancer. Avoid hot flash triggers, caffeine, alcohol, spicy food. You may be disappointed to hear they told us on the course that the worst thing for women to drink is red wine. Oh dear, so I moved to gin. But so there's always, you know. So dress in layers, lots of layering, sleep in a cool room. You can buy these thermal-regulating pillows, and there's all sorts. If you want to spend a fortune, you can. Consume cold drinks. And there is evidence that acupuncture can help as well. We're nearly there, ladies. Postmenopausal help. So this is where we really want to, a lot of us are just taking off in our careers, traveling, you know, buying new houses, maybe getting a new partner, who knows? But, you know, we want it to be the best time of our life. So it's the usual: tobacco, excess alcohol, drug, medication abuse, just looking at that. So we want to be doing all these things as well, promoting the healthy food and exercise. So here are the resources. So like I say, Dr. Louise Newson, she is just fantastic. Liz Earle is brilliant as well. She has some really good talks with Professor Michael Baum, who is the head oncologist in the UK. He's the one who brought in about the breast checks, and now he's saying, no, so many women have, you know, that breast cancer can be just lying there dormant for years upon years upon years. And he's now arguing for maybe not, that we don't need to be doing this. So it's really, really interesting to listen to those as well. And the Women's Health Concern, the British Menopause Society. So I would just ask that you're really, really careful on where you get your information, that you really know your sources, and that the information is evidence-based. And when you want to make decisions about your health, and in any kind of health, that you're looking at the evidence, and that you know, you're the expert. This is what we tell people all the time here. You're the expert in yourself. You know what you want. So I highly recommend these books. Estrogen Matters. Myself and Karen love this book. This is our bedtime reading, isn't it, Karen? It's not the kind of book you sit down for an afternoon and read. You kind of dip in and dip out. It can be hard going, but it's really, really interesting. Avron Blooming is amazing. Again, another top oncologist in the world who spent 40 years treating women with breast cancer. And he has all, Louise Newson and Liz Earle both have brilliant podcasts with him as well. And there is Louise Newson's book, Menopause, as well, which will tell you all the information. And then just to the Menopause Hub, that's menopause specialists here in Dublin. So I have no affiliation with them, just really good, positive, personal experience. Because unfortunately, my story with my GP was quite a common one in terms of you know, I knew what I wanted. I'd done my research for 10 months. And she's coming from a place of fear. And she actually, the words she said to me that finally sent me out the door was, would you not just put up with it? So I said, would you not off? So I've changed GP and now go to the menopause as well. And then this is Dr. Deirdre Ford, who's brilliant as well, trained, and she's over in Athlone, actually. She did work with the Menopause Hub. But I'm sure there's others. I just know of these two. And I'm sure, and some people have brilliant GPs who are interested in menopause and learning about it. Remember, GPs are general practitioners. They're extremely busy people. And we need to help them by going in and knowing, right, these are all my symptoms. This is what's going on. And we can only know this if we educate ourselves. So please, please tell all the women in your life, and hopefully for the next generation, they're not going to have to be scrambling around looking for information. In the UK, Diane Danzebrick, she's brilliant. She's a campaigner for menopause. She got menopause onto the curriculum. So in school, in secondary school now, kids are learning about menopause. So it's brilliant. So that's it. That was a lot. Oh, 9, not too.
Thank you. Thank you so much, Maureen. There's so much in that. It really is. I mean, it's such a huge topic that even just, you know, like you said, you want to keep this broad, but, you know, you can drill down to so many other different aspects of it, which is what I'm kind of thinking about doing to continue on this kind of series and this you know, this narrative that's, you know, we're starting. So we do have some questions coming in. The first one was, is testosterone needed to improve libido? I have just started estrogel and Nutrizan 3 weeks ago. Big improvement in aches and pains, sleeping and energy. Will libido also improve with some more time, or will I go back to GP and request testosterone?
probably give it, the 3 to 4 months on the estrogen. And and obviously as well, with sexual activity as well, the more you do it, the more you want it. So I think it's a case of, if there was no improvement in libido in definitely 4 to 6 months, then you go back.
Yeah. That's okay. So this one is about sleep. Since menopause began, my sleep has been disrupted. I keep waking up every 2 hours, no matter how tired I am. Any advice? This is going on a few years.
Oh gosh, yeah. So I mean, we do a whole 2-hour workshop here on sleep hygiene. I would really probably be worth really just tracking other symptoms as well, because obviously trying to find out what's the root cause for the sleep as well, I think. So maybe, just getting that climacteric green scale, start reading up more about symptoms, and then you might join the dots together.
Yeah.
But it may not be. It could be insomnia that needs to be treated with medication and CBT for insomnia. So, yeah.
Yeah. Is there I'm just thinking out loud here, with perimenopause and symptoms, and you have like caffeine as, one thing to kind of cut down on, is there evidence to support that, if you did cut down on caffeine, or even just like had it very early in the morning, that would, because it can make you sensitive to, falling asleep and staying asleep as well. I suppose, would that be something that you'd recommend?
Oh, definitely. Yeah, definitely. So looking at that, because that's what caffeine does. Adenosine is that's the sleep pressure that rises during the day, and then the caffeine masks that. So it's worth trying all the basic sleep hygiene protocols, and also tracking other symptoms as well, and just seeing what is this? What is the root cause? Is it stress? Is it the symptoms of perimenopause? Is it depression? I mean, that's what we do here with people with sleep problems. It takes a while. It's like investigating.
Okay. Actually, we have Isabel Baz here with us, who is a nutritionist. And on that question on caffeine, she says, yes, there is. Caffeine interferes with the liver metabolism of hormones. So
yeah,
that would make sense. Just on sleep as well, I just want to share something. I shared it with one of our clients actually recently. Silk pillowcases have changed my life, believe it or not. I know there's all this kind of, I can feed into the whole marketing thing, even though I've got a marketing degree, but I can believe all this hype on stuff. And, there's all this stuff about silk pillowcases, and you won't have wrinkles and all that sort of stuff. But I got one, as I put it down on my Christmas list, and I got one, and it's changed my sleeping life, because obviously with hot flushes and night sweats and stuff, it's really, really helped, because it just regulates the temperature, and you don't have that, kind of just sweaty feeling the back of your neck when you wake up on the cotton pillow slip. It was awful. So yeah, I can highly recommend them. They're very good.
Brilliant.
And Isabel also says they're great for anti-wrinkles as well. Eleanor has been my question person here. There's a question here about the Mirena coil. I have the Mirena coil for heavy bleeding. This is a good one, actually, Maureen. Now stopped bleeding. Will this affect me in delay of menopause?
As in, I don't get that.
So she had the Mirena coil put in for heavy bleeding.
Yeah.
And now the bleeding is stopped. So will this affect or delay the menopause? And it won't, because
no effect, because it's about estrogen.
Yeah.
So estrogen is the main driver. So that's the piece where we get most of the symptoms, because progesterone is just about the lining of the womb. It's about gestation, progestation. Think of it that way. Mm-hmm. So it won't, no.
Yeah, and actually, for the progesterone piece, you can actually get the Mirena coil put in instead of having the Utrizone. Yeah.
Yeah.
If that was what you wanted. And this is a little tip that's come from my sister-in-law. Postcards from Midlife is a good podcast that covers all kinds of things, from the best jeans to buy and skincare and all things related to menopause.
Ooh, brilliant. Postcards, what's it called?
Go back. Postcards from Midlife. Thanks, Claire.
Brilliant.
Yeah, it's a really fun one. Two great ladies running that one. It's just fun to listen to, and they cover absolutely everything, including, you know, you want to murder somebody, or how you're getting mad, or all kinds of things. Really, really good.
Love it. Excellent.
I like that murder one. That's really good. And the Latte Lounge is really good as well. I don't know if anybody's gone on the Latte Lounge.
No.
Yeah, actually, there's so many.
Yeah.
Postcards from Midlife. Oh, I like that.
This is another one. So I'm in perimenopause and started HRT last year. I found a fantastic page on Facebook called The Irish Menopause. That is a mind of information, all similar to what you have heard tonight. Louise Newson often talks on this page. It's a private page as well, so you have to send a request to join it. So that's The Irish Menopause.
Thank you.
On Facebook.
Brilliant.
And then there is so they actually have a podcast as well, The Irish Menopause, called Bits of Me. So all these podcasts are great because you just get these little nuggets of information that you kind of go, oh my God, that's fantastic.
It's brilliant. And that's what we need to do, just spread the information, and it's not taboo. And, you know, if everybody tonight just tells one more person, that's going to be over 100 women, you know, be fab.
Yeah. So I guess you actually beat me to it there, Maureen. I was going to ask you for, say, 2 or 3 take-home tips for everybody, that if they were just to take home 1 or 2 things to help with them.
Yeah, I think download the Balance app, because it's so simple, it's so informative, it's with you all the time. So you'll get into the habit, instead of scrolling Facebook, you'll go on the Balance app. It's really, really good. And tell everybody you know. Start to track your symptoms. So on the Balance app, you can track your symptoms. You can also download the climacteric scale. If you're going to, say, the Menopause Hub, they'll get you to do your symptoms beforehand as well. So become your own private investigator. Be curious about yourself. That's what really, you know, I've always been into health and fitness and curious. I'm very curious about myself. I'm very curious about other people. It's curiosity, not being nosy. But it's just be your own private investigator and start putting things together, especially this time of life, because, you know, we're in what they call the sandwich. We're the sandwich generation, isn't it? In between kids, elderly parents, busy work, COVID, lots of things being told we can't drink red wine now, stuff like that, awful stuff. So we just have to do the best we can for ourselves and for everybody around us. So yeah, I bug my friends, but you know, hopefully they listen to some of it. Mm-hmm. And then start conversations with men and women. It's really important. So many men are like so grateful to say, thank you, I got my wife back. My husband, he loves HRT. He only actually said it the other day. It's great. And so just, you know, talk to everybody. Tell, you know, when somebody mentions dry eyes and skin and different things, don't be afraid to talk about vaginal atrophy and, you know, about sex. And, you know, we tend to joke about it a lot. And because we're Irish as well, we tend to be a bit like, oh, vaginas. Ooh. But thankfully nowadays we're more open now. Nowadays, I know what my boys and around, they just talk about periods and stuff like that. So we just need to get, you know, now with us women, we just need to get more open. We don't need to let it all hang out, but, you know.
Yeah, absolutely. Yeah. Wise words.
Yeah.
I'd like to kind of echo that and just, you know, I've been just reading up over the last few months. There's a lot of women that, you know, go to their GP and their first line is to prescribe antidepressants, or, you know, the experience that you had yourself, Maureen. You know, my own experience years ago with my own GP, who, you know, was probably at the time menopausal herself, saying, you know, there's nothing wrong with you, you're grand, you've probably just got another sinus infection, here's an antibiotic. So yeah, knowledge is power. And if you download a symptom tracker or the app, and just follow it for a few months, and go in there, you know, to your GP or to your specialist, you know, like I did a couple of months ago, to the Menopause Hub, and just basically say, this is it. And, you know, within 15 minutes my script was emailed to my pharmacist, and that was it, you know, and I haven't looked back since. But yeah, just so you know, you know what your risks are, and you make that decision then. If they outweigh the benefits, then, you know, that's your decision. But I think knowledge is key.
Yeah.
Do we have any more questions? So this lady has said thank you, and she went on HRT 6 months ago, and it's changed her life.
Yeah, I mean, it really does. You can't, not for everyone, but I think for a lot, most people, yeah. If you get the right one, it can be trial and error too.
That's really, that's another point to make, is to have some patience. So the lady who said about the testosterone, so I myself, you know, I kind of just went in there going, you know, and what about the testosterone? Can I have some of that too? And she said, well, you know, we'll test your bloods and we'll see what they come back with. But, you know, take your estrogen, your progesterone, come back to us in 3 months. So in that time, they'll probably have the blood test back. But I know myself, you know, I have still the brain fog, still the libido, and my own strength, like just strength to train is just not there, like that fatigue bit. That's the other little bit that, you know, can be missing with low testosterone, is just that fatigue that can happen, where you could be on a Zoom call like this, or, you know, you could be teaching a class, and you're all of a sudden you're going, oh my God, I could actually just pull over and sleep. You know, it's like as if you've just been drugged.
Yeah.
It's the most bizarre feeling. So that's low testosterone as well. But yeah, to be patient, you get there in the end, or else they'll just kill you, Maureen.
We listen to post.
We have a bet on that I'll be, you know, absolutely rocking by June. So.
Oh, I'm really happy. Thank you. I'm one of Maureen's friends. Yes, she does bug us. We're all healthier and happy for it. Oh, thank you, ladies. And they're still walking with me, so
that's a good sign, isn't it?
Yeah. Oh.
Okay. Well, I think we'll say thank you to everybody, and thank you very much to Maureen as well. I don't think we have any more questions. If anyone's got a burning question now, put it up there in the chat box. But otherwise, you know, we will send this on to you, and yeah.
Thank you so much, everyone. Thanks for your patience.
Yeah.
Thank you.
Great. Thank you, Maureen.
Thank you, ladies.
So you're very welcome.
Thanks a million, guys. That was great.
Thank you.
Very welcome,
You're welcome. Thank you.
Bye, all. See you in class.
Bye. Bye.
Bye. Fantastic.
Thank you.